Tonight, we have a very distinguished panel with us. In 2014, as many of you know, Children's Hospital Oakland and UCSF Benioff Children's Hospital San Francisco affiliated. With that comes a lot of opportunity. One of the biggest ones is what we're going to talk about tonight, which is mental health, and really one of the most crucial ones. I'm sure there's a reason many of you are here tonight, and this has been a really attractive topic for people to discuss. And we've been working on this before the royal family came out last week with their support of how important it is to talk about this, so we were ahead of the game. But we have welcomed a new member of our team somewhat recently, Dr. Brian King. Brian joins us from Seattle Children's, where he built really one of the top-notch mental health programs and created the Autism Center there. He is now the vice chair of adolescent and child psychiatry at UCSF and is an MBA, which I think makes our finance folks really happy as well. But he is leading the joint effort between San Francisco and Oakland to really innovate and develop new ways that we can be delivering mental health services to kids all the way on the continuum. So where are the kids now and where can we meet them where they are? And then how do we continue to work with them through the course? So, Brian.
Thanks, Erin.
Really happy to have you. Thanks for kicking this off. And I forgot to add, I was asking Brian what he has learned most here about being in the Bay Area in his time, and he said BART. Mm-hmm. So
that's right.
Thank you.
Yes. Thank you. And thank you all for coming. It really is terrific to see a full room here on an evening where people are coming to focus on mental and behavioral health issues. I came here from Seattle a few months ago now, specifically because the opportunity that was being presented and which clearly is within reach is to do something transformative for the mental health landscape in the Bay Area. We have a UCSF health system that includes 2 children's hospitals, plus the Langley Porter Psychiatric Institute and clinics, plus the Zuckerberg San Francisco General Hospital, plus. And the opportunities just keep extending. And we are poised to take advantage of that and want to do something really special here. To become the epicenter of what an integrated mental health system should look like in working with and identifying our community partners and ensuring that we absolutely take full advantage of all of the resources that we have on both sides of the Bay. And tonight we're going to have a really interesting chat about mental health issues, but before we go in there, I thought that I'd like to talk about orthopedics. So about 2% of people every year experience fractures. That's just slightly above 2% is the population prevalence on an annual basis for fractures. And one question that I have of the group is how many of us here have ever broken a bone? So it's very common. Now, one of the things that I noticed growing up was when a child in school broke a bone, he would come in or she would come in with this marvelous cast on the arm, and the entire class would ooh and ah and go up and write well wishes on it. It was a very public display. Look, he has a broken bone, and we as a community are going to support him and well wishes, and it made you almost feel like going out and breaking a bone. So that you could enjoy that. And nowadays they're fluorescent casts, and it's basically the same, that there's no secret, and the entire community rallies around. What a difference it is when it comes to mental health issues. So I'm not even going to ask for a show of hands, because that would frankly just be the end of the evening. But if I were to ask how many of us have experienced mental illness, personally or in our family, but that's not something that we publicly display in the same way, and it's not something that elicits the support from the community in the same way. It's something that we just don't talk about. But really, what's the difference? What's the difference? If we put enough stress on a healthy bone, it will break. That's just the way things are. And if we, have the right combination of genetics and environmental factors, and it results in the similar experience of stress, we expect the system to talk back, and that expresses itself in illnesses. And 2% of the population experiences broken bones, 20% of the population experiences mental illness. And if we go through those disorders, we add up, percentages of each one, 5% with ADHD and 1% with autism and another 5% with mood disorders and 6-7% with anxiety disorders, and pretty soon you're well above 20% in terms of the population prevalence of these disorders. It's something that clearly is very prevalent. Suicide is the third most common cause of death for children aged 10 to 14, and the second leading cause of death for children 14 to 24 in the world. More than cancer, heart disease, stroke, pneumonia, influenza, and diabetes combined. And the suicide rate has not changed over the last 2 decades at all. It's virtually been flat. Here in California, we have one of the higher suicide rates in the country, and in particular counties in Northern California, we're actually above the national average. And so, so we're talking about really significant and very serious illness, the potential for death associated with some untreated mental disorders. In our local school districts, the Mount Diablo Unified School District, and I'm probably not going to get this right, the Acalanes School District. 17% of kids report experiencing suicidal thoughts in surveys of 9th graders and 11th graders. 17 and 18% respectively report that in surveys. The last one was done in 2013. 30% report experiencing depression that's so severe for 2 weeks at a time that it impairs their function, which would meet criteria in many cases for the diagnosis. Teachers, staff in the schools report that nearly 60% of 9th and 11th graders experience moderate or severe depression at school. A substantial portion of the population with these disorders goes without treatment. And part of that is because it's hard to get in, and part of it is because we don't talk about it and we don't recognize it. So what we're going to do tonight is take advantage of 3 phenomenal experts here. We have a range of looks at the population and also at mental and behavioral health, ranging from primary care pediatrics, Dr. Julie Herbert, who's with La Marinda Pediatrics. Dr. Herbert did her medical education in Chicago, at Chicago Medical School, and then came out here and did her pediatric training, was a chief resident, and then joined La Marinda Pediatrics 10 years ago, in 2007. The same year that Dr. Petra Steinbuchel joined Oakland Children's. Petra is a child psychiatrist who did her training medical school in Georgia, and then came out here and did her psychiatry adult training, and then went to Massachusetts General Hospital to get her child psychiatry fellowship, and then thankfully came back out here and joined Children's, where she's the director of the Department of Psychiatry at Oakland Children's Hospital. And And then Brad Berman also went to medical school in Chicago at Rush, and then did his pediatric training at Michael Reese. Is board certified both in general pediatrics and also developmental and behavioral pediatrics, and has a long history of a relationship here with Oakland Children's Hospital, but also I think has been the developmental and behavioral pediatrician for the East Bay and beyond. And so we're going to take advantage of all of their expertise and start out as we frame the discussion around how do we recognize what's typical in terms of feelings, thinking, and behavior, and when the bumps and bruises, if you will, rise to a level that we need to be more concerned about it. And then we'll think together about promoting resiliency, and then end with focusing more on when we should be thinking about calling in the cavalry and how we access services. So going in that order, I think it probably makes sense, Julie, to start with you as we think about, because you're on the front lines in general pediatrics, and when families come in. Actually, before we do that, let's just take a couple minutes to hear about your particular interests, if you'd like, and then I'm going to ask you the first question.
My interests. Can you hear me? My thing keeps falling. So, my interests right now are trying to keep up with my kids and keep up with my changing practice. So that's kind of my main interest. I guess. So you're on the front lines, and you probably are seeing lots of kids and families coming in with questions about whether what they're feeling, thinking, experiencing is typical or not. It's probably one of the biggest things that I do. I mean, it probably occupies at least half of my time. It may not be half of my patients, but it's a huge percentage of my patients that I see are coming in with concerns about behavior, concerns about mood, concerns about how their kids are doing if they're struggling, and all that sort of thing. It's, to me, I feel like I get families that reach out to me so often with those concerns and questions, and so I feel like in reality, so many people are recognizing what to them doesn't feel right and doesn't feel typical, and that to me is one of the biggest things, is if their families are saying this just doesn't feel right, that's one of the big reasons to reach out. They just have an innate sense that they know this is not my child, and this, you know, they reach out to me. I'm sort of bleeding into the last thing, I guess, too, but and that. So there are times where I see patients and I am talking with them, and we start to talk more and more and more, and realize that there is a problem that they start to discuss. And that happens a fair amount of the time, but a lot of the times that I have families that are reaching out to me. And most of the time they are recognizing there's something that's not quite there. I think sometimes families are saying, is this a problem? And we have to have lots of long conversations about it. And
What are some of the common concerns that you see, some of the most common?
Well, interestingly, I mean, for younger kids and school-age kids, it's much more the how are they doing in school, how are they adapting in school, are they struggling with that piece? And then the teenagers, it's much more mood-driven, and it comes to me often not as I think my child is anxious or my child's depressed, but it comes to me as my child's having headaches, my child's having stomach pain, my child's so tired, oh my gosh, she's so tired, like all she wants to do is sleep all the time. So it comes to me often in many, many, many different ways. And every now and then I get the call that, you know, oh my goodness, I'm so worried because Jane is just so anxious. But it usually doesn't come that way. It's sort of masked, if you will, under the guise of a different issue, or it's manifesting for that person in that way. And then we spend time trying to sort through what is the driving factor behind that issue, and we often wind up that there is a mood issue that's going on, and then trying to access my fabulous colleagues.
Yeah.
So it's always interesting to see how things are presenting, and it is not typically straightforward in the, I'm anxious, what do I do?
Right.
You know.
So there's a bit of investigative work that you need to do when you're presented with physical symptoms that might be manifestations of...
Absolutely. Absolutely.
Okay.
And I think one thing that is hard sometimes is, I think, to what you said in your introduction, people don't often want to accept or acknowledge that it could be a mood issue, and I often get, but there's got to be something wrong. Like, there's got to be something physically wrong, in the sense of, well, they have to have something wrong with their intestine. They're having such severe stomach pain, or they must have something going on structurally in their brain, or something, you know, that's causing these headaches. And it often is difficult to try to get together to say, okay, you know, we've done all of this work, and now we need to investigate this other side. But there is definitely a block between people being able to accept that, you know, they have the symptom, but to being able to accept and understand, and then move on to get the right help, because that's the most crucial piece. So.
Right. My sense, Dr. Berman, is that it rarely is completely either or, and that you probably have to do some sorting as well. I wonder, before I task you with that, if you could say a little bit about your clinical interests.
As many have heard, my clinical interests have been shifting over the past few years, so it's very, very small in focus. One is to tell the stories and be an advocate for families raising children with diverse abilities. And the second is around advocacy and understanding of how our culture, both domestically and internationally, bring resources to bear in a much more meaningful, impactful way for children. So, two small issues.
Yes, two. Yes. So in your spare time, then. So the population that comes to you has already seen Julie, perhaps, and are referred to you because there's an opportunity or a need to take a deeper look at what's going on. Is that fair to say?
It is, and one of the things that the introduction apparently did not mention is that you're very good at mind reading. Because I was thinking very much as you were speaking about this, Julie, about sort of this arbitrary notion that we have of physical versus mental or emotional. It doesn't exist. It never existed, this psyche-soma connection. Fortunately, when I did my training, fellowship training at UCSF, and then my clinical work at Children's, it was from that old biopsychosocial model, right? Which just, it keeps getting renamed, but it's still the same.
Right.
And so it's always the relationship between that, and then really trying to tease apart, which I think you and your primary pediatricians do so well, and I've done that, is how to begin to look at the factors that, as we're going to talk about, either promote success and resiliency or lead to areas that become less functional as time goes by. It's not always easy, of course.
Right, right. Petra, if the last stop on the train or a different stop on the train is with the psychiatrist, and people have sort of gotten past the initial reluctance or difficulty, and we have a diagnosable disorder, what comes next?
So usually by the time people come to see me, there is an identified issue because I usually have to jump through a lot of hoops to get in. And I think really it's about being able to get past the stigma, being able to name it, and then being able to move on towards diagnosis if appropriate and figuring out a treatment plan. I think part of that is really, cultivating a relationship where people trust you and, feel comfortable with your recommendations.
Mm-hmm. So why is it so hard to get in?
Great question, because there are very few behavioral pediatricians and very few child psychiatrists. So last numbers I checked, I think there are about 800 behavioral pediatricians and about 8,000 child psychiatrists in the country, and the estimated need is about 40,000 to manage the demand. So very few.
So what do people do while they're waiting to get in?
It's a really good question. So we really lean a lot on our colleagues in allied professions, so psychologists, LCSWs, marriage and family therapists, and also working with the schools to develop educational plans and where can we build other supports and scaffolds that help.
Okay. So we'll come back to where to go for help, I think, at the end. But while I have you, and I didn't give you a chance to share your clinical interests, I know one of them is complex trauma.
Right. So I was drawn to come to work at Children's Oakland almost 10 years ago because I really love the interplay with medical illness and how that plays out, including complex trauma, and we see a lot of that in Oakland, as well as ADHD and anxiety disorders, and then more broadly, just improving access to care and decreasing stigma around mental and behavioral issues.
So I want to stay with that for a minute, and as a bridge to resilience. So if we think about someone who's experienced a traumatic event or has had some other experience from which there may be a need to rebound or demonstrate, express their resilience, what are the things that we can do to promote resilience for folks?
So I think this is something that starts really early, and it's about having a solid attachment, a solid caregiving experience whenever possible. For many people, that's not always possible in a consistent way, but we know that if you've experienced one trauma and you've had other prior traumas, then you're much more likely to develop post-traumatic stress disorder or other complications. I think being able to help cultivate emotional intelligence in kids as they grow up, so being able to name feelings, understand them, know what to do with them, know that a broad range of feelings is normal, that we can't just protect our kids from every frustration or anxiety or worry or rescue them, but teaching them to be able to struggle and know that you can overcome it, really, that it's about recognizing that you have your inner strength and really cultivating that throughout, so that when you do experience a trauma, whether it's a broken arm or something else, that you know you will get through it, and being able to talk about it with others.
Brad, I wonder if you can speak to the question about whether people are gifted with genes that help them to be more resilient or not, to be more sensitive. To speak to the role of genetics and environment, if you will, to
thanks. It's a fabulous question. So for those of you, there are many professionals out here that know the term epigenetics, and for those of you who don't, it's the relationship of our inheritable potential genetically with how it's addressed and expressed and promoted, or shifted negatively in our environment. And there are some people that are genetically imbued with the potential for resiliency. But it's resiliency in the right environment, the right community and adult support. And like everything, it sort of waxes and wanes, and it never comes without a price. So even those children who seem to be doing so well in the face of adversity, however one determines that, there's always a cost. Now, the cost may not be as catastrophic as post-traumatic stress disorder, but it may be asthma, and it may be eczema, and it may be chronic headaches and other things. And I'm sure that you see this quite frequently.
What are some of the things that you do with families to help promote resilience for kids?
we could spend hours on not what I do, but what I think kids need or in their environment. I think one of the biggest things is talking with families about, I'm trying to think of how to phrase it the right way. I guess it's learning when to sort of step back from their kids a little bit and how to hopefully provide a really supportive environment, but that is not a really controlling environment, so that they can learn the abilities and the skills to struggle and learn how to pull themselves up from that, because that's one of the most important things they need to kind of figure out how to do, especially through adolescence, is how to fail at things and then how to recover. And so trying to help families understand how to do that is it's really difficult, because it's hard. Everybody wants their kids to do really well and to jump in and try to help them any way they can, because that's what you want to do as a parent, but trying to understand when to step back and say, okay, you didn't do so great there, you're gonna have to go try to figure this out. And it's just through conversations and spending time, and it's one thing that I think helps so much to have known families over time, is to have that relationship with them, because I've maybe known them for years and have seen where they've been and where they've come, and to be able to talk to the parents and say, okay, you know what, now is when you kind of might need to let go a little bit and let them do this. And knowing, like Brad said, there are some kids who seem to do so well in the face of adversity. There are some kids who seem to thrive and do well in the face of the most insane schedules of activities and things that they're doing. And then there are others who just can't do that. And trying to understand when your child, your friend might be able to do 15 hours of dance a week, but it may not be quite right for yours, and that's not a failure. You just have to step in as a parent and take them back and say, okay, this isn't right for you, and we're gonna find something else, and then I'm gonna let you go do that. And so trying over time, I think, by being able to have a relationship with people, it really makes a huge difference to be able to talk to them about these things, and hopefully they bring them to me, and that we can, over our visits, talk and work and think about these things more. So.
Mm-hmm. Well said.
So the prevalence of mental disorders in kids and adolescents appears to be increasing over the course of the last decade. And I wonder, coming back to the genetic and environmental question, maybe ask you, Petra, do you have any thoughts about why it is that we're seeing these increases?
I think there are a few factors that contribute to that. One, fortunately, is that I think stigma is decreasing, that we are becoming more aware and are more okay with naming that this is depression or anxiety. Another reason is that I think one of them actually is that the prescription rate for antidepressant medication has gone down amongst pediatricians because of concerns around prescriptions, and with that the suicide rate has increased somewhat, and so there may or may not be a link there, but that's how the timeline has gone. Another piece is that I think kids are really overscheduled, that they don't, they're always in their phones, they don't have the relationships, they don't have the time to talk. I mean, I feel like it's a very different time, than when I grew up, where there was just lots of free-form play and just being able to, spend time together and talk, and for families to be able to talk and have more dinners together. It's so often, I ask when I get my initial histories, do you have family meals together? And so many of the times, no, they don't. And so being able to kind of talk through problems, get rid of that stress before it adds up to the point of becoming, depression outright.
I guess one other question that I have for you while we're talking about the actual illness is, do we have effective treatments for for these conditions?
There are very effective treatments, and some of the treatments, if it's really just mild to moderate, just respond to education. You're not crazy. This is something called depression, and there are really clear things that you can do, like taking care of yourself, getting good sleep, turning off your phone, eating well, exercising, and then if things persist or are more severe than that, then using different types of therapies. Even more time-limited therapies, 12 weeks, 20 weeks, not spending 2 years on someone's couch, but really, just figuring out how to think about your problems differently, how to solve them in a more effective way. And sometimes when necessary, if it's more severe, then medications can be very effective as well.
Mm-hmm. So, when it's time, or I'm thinking about the signal for moving on to a next level of care.
Can I mention one other thing related
Please.
to that, which I couldn't agree more, is expectations. And how do we shift expectations, first, of course, beginning with parents and then children themselves, schools, communities, and so on. And I glibly suggest this, but it's, I think, an example, and that is the most recent DSM-5 diagnosis, which is the college hysteria syndrome.
Let me check my book. I'm
yes.
not sure that.
It's DSM-5A. And it's just such an example, and obviously it's in certain socioeconomic, cultural elements, but it's an example of sort of a raise in stressors which lead to symptoms that you see really quite frequently in acute depression and anxiety episodes because of societal and cultural expectations, and that this has so much to bear in terms of our children's mental health and behavior.
Mm-hmm. Well, I'm glad you bring up the college, because that raises another issue about what the period of risk is for these disorders, and whether it ends at age 18 when you officially move out of childhood, or whether there are other other transitional stressors like college that would be periods of great risk. So I may have answered the question as I've asked it, but is there a time when we can just sort of sit back and figure that we've made it through the vulnerable period, or is this a lifelong resiliency, something that we want to build over the course of our lifetimes?
Oh, over the course of our lifetimes?
Yeah.
Oh, certainly. And yes, over the course of our lifetimes.
Mm-hmm.
And that's what the life journey is.
Mm-hmm.
Yeah, I mean, I think it's about building the right skills at each step along the way, and a lot of that has to do with figuring out how to solve problems and knowing that you can get through things. But certainly, if you don't allow that struggle, I see a lot of kids who do go off to college, and they have their first really severe episode of anxiety or depression, or sometimes that's a time when other illnesses, including like bipolar disorder and schizophrenia, can come on for the first time. And so really wanting to think about, how do you arm someone with the right tools, and also, for your kids to know when to ask for help is a significant thing, especially as they start to launch and presumably move away from home.
Mm-hmm. So how do people access care when it's clear that they need it? What do you do, Julie? Yes.
Thanks.
Yeah.
Well, I mean, I think it starts by coming in, of course, like we talked about, to hopefully see your pediatrician, and hopefully people have a good relationship with that person and have developed one over time. And it's, I think, one of the most valuable things that you could try to create, that bond and that relationship, and that person that you've known and has seen you for hopefully all kinds of well checks, but hopefully a whole bunch of other stuff that's happened in your life. And then you work with them, and then there gets, I feel like once we've done so many things and met and evaluated and investigated, there's often a lot of stuff that we can do and I can access. And the wonderful thing is that I have access to people like these guys to call and say, here's what I'm thinking, or are you comfortable with this plan, until they can't get in to see one of you, or accessing some of the amazing help we have in the community in terms of, you know, therapists to help with CBT and DBT and just so many different modalities. And while access is really limited to a lot of you guys, we are lucky in the sense that we do at least here have a large number of great providers. At least we're not in some teeny small town in the middle of nowhere where we have none. We do have pretty good resources, and so we try to start accessing that. And then, if we're still struggling, we then know we need to move into the next level. Of course, depending on how what's coming in the beginning, to what somebody's coming in with to present with at the first place. So, but.
So. CBT and DBT?
Sorry.
Petra, can you
Sure, yeah. Could you please explain? Those letters stand for cognitive behavioral therapy, and then DBT is dialectical behavioral therapy. And so CBT is something that's been around for many, many years, and it's really looking at how do your thoughts and behaviors and feelings all connect and interplay, and if you can change maybe one of those, like how you're thinking about something or how you're behaving, then you change the others, and that really can improve your mood. And it's something that's, you know, fairly time limited usually, but can be really effective. Sometimes just by itself can be enough to treat major depression, or sometimes together with the medication. And then dialectical behavioral therapy is a therapy that has been around for about 25 years and just starting to gain more traction in the adolescent population in the past 10 or 15 years. And it's the gold standard treatment for people who present with kind of chronic intermittent suicidal thinking. And with that, it's been really effective also at treating substance use and other mood dysregulation disorders, so it can be really effective.
Great, thanks. I want to end with one last question that leverages Dr. Berman's experience living at the intersection between primary care and psychiatry, and also your interest in policy.
Wow.
And ask if you were king of the world, and you could actually make some changes in the healthcare system that would improve specifically access or outcomes. What do you think we need as a community to be focusing on? What could we do to make things better from a systems perspective?
That's a great question. One I was completely unprepared for in a way. Yes. And yet, this is what we do every day. One is, I think, I don't use this word very often, I would really empower primary care medicine to be able to do more of what they do so well, which is to know the families and know the children. The second is really, in a very similar way, is to help schools, public and private, from a mental health point of view, as well as in a redistribution of the stress and the pressure, so to speak. Now, that's a very lengthy comment, but yes, we need more specialists. There's no question. We need better medications. We need additional selective treatments like CBT and DBT and all the other Ts. And yet, it's really how do we address it, most of all at the ground level. Mm-hmm. And the two systems that are the most at ground are, well, there's several. It's parents, of course, and then it's primary care and education. And it's how do we really build those up to address this at a much more fundamental level.
Mm-hmm. Great, thanks. Well, I want to thank all of our panelists for putting up with my, I was going off the script, just so that you know. So we were throwing new questions that they weren't necessarily expecting. You guys were great. And now I'd like to open it up to questions from all of you. We have some time and microphones that are going to be moving through the room.
I was wondering if you could talk a little bit about your perspective on the confusion that is growing around ADHD misdiagnosis and potentially how it relates to trauma or developmental trauma?
That sounds like one for you.
So that's a common diagnostic question that we get, and it's sometimes really difficult to tease out. I mean, there are a lot of reasons to not be able to focus well if you're really struggling with, thinking about trauma or, sometimes people who have experienced severe trauma really check out of reality every so often. But just having kind of baseline anxiety can interfere with your ability to focus if you're just, thinking about all of your worried thoughts and not really focusing on the task at hand. So with ADHD, I think it's really something that usually is there from early on, and sometimes there's only inattention, but sometimes there's also hyperactivity and impulsivity, and those are usually pretty prominent and have been there kind of all along. When someone's experienced really considerable early trauma, sometimes it can be really hard to tease out. And personally, I'm just a pragmatist, and so thinking about what's going to work. So getting a school plan in place, being able to access appropriate therapy. And sometimes you can't tease it apart, and sometimes a stimulant medication also can help someone focus enough to meet, those academic milestones that they need to, for as long as they need to, and then go from there.
In addition to what Petra is suggesting, which is wise as always, is my shameless plug for why we need centers of excellence of care, such as UCSF Benioff. And I think of the population of children in foster care. So how do you sort out developmental trauma, primary attachment issues, genetic inheritance, that epigenetic experience from the phenomena or the symptoms, if you will, of what we see? And frankly, sometimes it is so complicated that we really do need centers of excellence to be able to sort that through and continue to work with families and the various community providers in that regard. It's not easy. So thank you. It's a good question.
Thank you so much for this. One question I have, back here. One question I have is, when working with families and working with parents, can you name a couple of resources you'd recommend, books or great articles to help parents think more about resilience and de-stressing and all that stuff that we want to help support parents in supporting their kids? Can you name some books or articles or anything like that?
So there's one book, The Parents We Mean to Be, that talks about really, not doing the helicopter parenting thing and kind of stepping back. And I think, there's been different things in the media around like tiger mothers, and, certainly not suggesting to go to that level, but I think there's a way that we've culturally kind of adopted this. Everything is great, right? Everyone gets a prize at a party, or everyone's a winner. And that sets kids up to have kind of poor self-esteem and to really always be expecting that praise. And, the work that they produce is actually not worthy of a gold star or blue ribbon. And so, and then they go off to college and they're like, wait, I'm not getting straight A's, and I need to call my parents to get me out of that test tomorrow, and because I haven't prepared, So I think being able to step back from that, and that's a good book that highlights those challenges. It's The Parents We Mean to Be. There's another part to it, and I'll have to look it up and get that to you. I can do that once we break.
What do you suggest?
I have more little kid books. I have more little kid books I can think of.
There's a classic, which sometimes is really useful, called The Hurried Child by Daniel Elkind. And sometimes it's a little too Piagetian thematic, and yet he's really spot on. And it is as appropriate now as when he first wrote it several years ago.
Thank you all for being part of the panel tonight. I came to the discussion this evening sort of looking through two different lenses, one as a pediatrician and one as a parent of 3 young children. And my first question was actually very similar to the one that was just asked, so I will spare that, but I will add 2 cents about resources. One was a book that's called The Blessing of a Skinned Knee. It's very much based in Jewish theology, but it's an excellent book that I think teaches some very practical points about how to foster resiliency. And the second was an excellent TED Talk that I heard by the former Dean of Students at Stanford University. And I'm going to blank on her name, but it essentially talked about backing off a little bit and just allowing your children to be children and not having such high expectations, and it was beautifully done. So if you Google Stanford Dean of Students and TED Talk, I think it's an excellent one to share. My second question, though, was really from, and perhaps this is best directed to you, Dr. King, about how we can better equip our general pediatricians to address some of these issues. I trained at the University of Wisconsin, and to this day I still feel very inequipped to be the frontline person who is dealing with a lot of mental illness, particularly in the patient population that I serve. And are there any educational things being done either at the university to help teach our medical students or our residents to better equip our trainees to be the frontline staff to deal with some of these issues?
So thank you for your question. That's a really great one. There's tremendous competition for time during the course of training, postgraduate training, and even within a specific psychiatry program, there's constant jockeying for who gets airtime when the amount of knowledge that we need to impart seems to be growing exponentially, but the duration of training is fixed. And so it's very hard to get pediatricians who have a million things that, as you know, to cover, a significant chunk of their curriculum that's devoted to behavioral health. And I think what's happened is that a lot of that education is jumping into the deep end of real-world practice after you find yourself out there. And so one of the approaches that we have taken, in addition to being on call and ready when the opportunity presents itself to incorporate trainees, and one of the places where we do that is on the consultation liaison service, where the pediatricians are electing now sometimes to spend time with the psychiatrist who's seeing kids who happen to be in the hospital and for whom there are questions about possibility of mental or behavioral issues. But one of the things that we're doing is trying to leverage the resource that we have in terms of behavioral health to support primary care providers after they're already in place in the community. And one of the things that we did up in the state of Washington and also in New England when I was there before was to roll out a hotline for child psychiatrists that primary care providers could call and access in the moment. So we called it the Partnership Access Line up in Washington, and not long after we had it up and running, the state of Wyoming came knocking on the door and wanted us to cover them as well. And interestingly, the legislature in Washington funded this initiative. And in Wyoming, it was the Office of Medicaid. But basically, it's a win-win-win situation where you have the opportunity to provide just-in-time education for primary care providers who are with a child or family. It's followed by a note to memorialize the conversation so that it's not, I'm still taking a risk here. After we hang up, you're not here anymore, and I need to. So it's memorialized with a formal consult that goes back to the office, and coupled with access to resources and so on. And we're exploring. Petra and I literally had a meeting this week earlier to talk about how can we get something like that in place to support folks here in the Bay Area and frankly Northern California and beyond. The other thing that we're doing is trying to leverage the resource that we have in terms of behavioral health to support primary care providers after they're already in place in the community. And one of the things that we have taken, in addition to being on call and ready when the opportunity presents itself to incorporate trainees, and But again, to your point, there are many opportunities. The other is to provide ongoing educational opportunities, and the ways that we've done that have been to hold continuing medical education conferences in regions that that people can attend, but also to put online resources up for people to access around common behavioral and emotional conditions that come up.
Hi. How do you know? I'm a mom with 3 young children, and I sometimes, everything ebbs and flows, but I have one child in particular who her emotions seem to sort of ebb and flow, and the minute that I finally make contact with the pediatrician, it seems to be when everything starts to calm down, and he'll say, oh, well, are there problems at school? No. Are there problems with friends? No. But on the home front, I feel like I'm losing my mind. So how do you know when to raise the red flag and say, we really do need help? Even though the schools aren't alerted, and things in general seem to be going okay from a friendship standpoint, but at home you're just pulling your hair out and feeling like you don't know how to deal with certain behaviors. I just feel like this is sort of a common theme. And then the minute, like, for example, I do have an appointment with my pediatrician next week, and I'm like, oh, well, things have been calm now for 2 weeks. Maybe I don't need the appointment. But I don't know. I just feel like, how do you know if there is a real problem or not?
There's a really old adage that always applies. If a mother is concerned about her child, she's right until proven otherwise. And with all due respect to fathers in the room, myself included, and I'm a pediatrician, if that's that trust your gut thing, but there's actual truth to this, and this has even been studied in research. If you are concerned, follow that concern. It's up to all of us, helping professionals then to determine what that concern may be, how valid is the concern, what that's about. But if you're concerned, act upon it. And if you're not being heard, and I'd love to hear your response to this. Now, you got to understand, Julie here is phenomenal.
Thanks,
and
Brad.
she listens. And if you're not being heard, speak louder until you're heard. And I'm being very serious about that.
No, I would agree 100%. I mean, I think it's so important to go to the appointment, because even if you're at a good place, you've been not at a good place, and you want to bring that in and dissect it and talk to somebody about it. And like what Brad said, if you're not being heard, yes, talk louder. If you have to yell, you can. And then if you're not, you find somebody else to talk to and talk louder to. And it doesn't mean that person isn't wonderful and great, but maybe isn't working for you and isn't understanding where you are for whatever reason. And so then I think taking it to a different person if you don't feel like you're being heard is really, really important. And you should feel 100% in your right to do that at any point. But I think when you have, it always happens. I mean, you come in the office and people are like, I swear they looked horrible this morning, and they're fine, or they were acting like a maniac, and now they're like sitting there like coloring, it just happens. But I think to be able, and even sometimes to come in and say, without your child, and say, here's what I've experienced this past 3 months, and to have maybe written some things down, and to say, I need a time to come in and talk to you about what I've been experiencing so I can figure out, is this right or wrong or normal or not. Those are some of the most valuable times, because if you can come in without your fabulous child, it makes it so much easier to talk and dissect and really kind of come together about what is happening. But if you feel like you still have needs that are being met, then you have to just keep asking for someone to help with those needs. I mean, thank you.
So we have time for one more question.
Sure. All you
thank you for saying that you think schools are a place where this can be worked on. I wonder specifically what schools these days are under a lot of pressure to provide a lot of services, but I'm wondering what specifically you think schools can do more, and if you partner with schools in any way to provide services or programs or anything like that. That makes sense.
I would be willing to believe that the 4 people on this podium partner with schools and educational systems constantly. First of all, children spend more conscious waking hours in school systems than they do anywhere else, when you think about it, or pretty darn close. It's a complicated question that is worth a discussion at another time. It's about expectations, truly. It's about expectations of what an academic system can accomplish in 180 days. It's about what do you accomplish in 5.5 to 6 hours a day. It's about how do you provide individualized or somewhat individualized education, and then paying attention to the girl who's got repeated stomach aches every Monday and Wednesday, and then the boy who's sitting in the corner at recess every day, every week, in a classroom of 28 to 35 children, in a school that's impacted, and you begin to get the idea of what I mean. So it's not just a question of hiring a few more people here and there, but I think it really requires a revisitation of our, and I mean our, understanding and expectations of what we assume we're sending our children to and what we hope to be able to gain from it. And then again, advocacy as a partnership continuously between parents and their educational teachers and principals. You don't need physicians for that. You may need physicians to help with filtering and advocating and coming up with ideas. But it's really about that communication and that willing partnership. And it is a partnership. Do you have anything you want to add?
No, I think that's lovely. The only things I would add is just that, you know, schools can be such a great and easy place for kids to access care. I mean, having that on site sends such a strong and powerful message, right? That, yes, you know, this is okay. The 20% will hopefully access care much sooner than they would if they had to talk to their parent who may not be okay with naming it depression, and, you know, they can go and get a preliminary evaluation first. And then I think it sets the tone that we care about these things, you know, from that particular school, right? That these issues are important and we're going to be attuned.
I mean, Children's Oakland for years has had an award-winning nationwide adolescent health program in some very challenged schools in Oakland that used to be designed by Barbara Staggers. And so having the opportunity of those services built into that, again, in a willing partnership, it creates a community, is really, I think, an optimal model.
All right. Well, I want to thank you all for coming again tonight, and please join me in thanking our panelists for